It's my distinct pleasure to introduce the Martin I. Broder Education Day. I'm Katie Jobbins, one of the Associate Program Directors in the Internal Medicine Residency, and we are very excited for our special medical grand rounds today, which will be Sustaining an Anti-Racist Academic Medical Center by Dr. Utibe Essien. Now, just a little background about the Martin I. Broder Education Day. Dr. Broder has had a very extensive career. He was practicing at Metro Health in Cleveland, Ohio, where I actually trained as well too. He won many teaching scholarships from the American Heart Association and was the chair of the Department of Medicine at Fairview in Cleveland, Ohio as well. Most importantly, though, he came to Bay State and was the chair of our medical department from 1982 to 2002. He has received extremely numerous citations for excellence in teaching from Tufts University School of Medicine. He also worked for 2 years at an artificial heart program for the NIH and has been faculty at numerous schools, including Case Western Reserve University, Georgetown University, and Tufts, where he is now a professor of medicine. Each year when we have the Martin I. Broder education series like this, we normally have dinner with our guest speaker the night before. Sadly, we weren't able to do that this year, given the COVID pandemic. But I thought I would say something that Dr. Broder actually spoke of last year at the dinner, which I wrote down because I thought it was so important. Education is important. Our trainees are the heart of our hospital. Changing the mindset to see its value takes time. With that being said, I'm very honored to introduce my friend and colleague, Dr. Utibe Essien. He's an assistant professor of medicine at the University of Pittsburgh and a general internist who focuses on health disparities with his research at the VA Center for Health Equity Research and Promotion. His research focuses on racial and ethnic disparities in the use of novel therapeutic management and chronic diseases, including atrial fibrillation. He has recently applied this research framework to the COVID pandemic and rapidly becoming a national expert in health disparities that disproportionately affect minorities with COVID-19. He is a fierce advocate for diversity and anti-racism in medicine, speaking nationally on this topic. Many of you may have heard him on the podcast, The Curbsiders, and co-host the Anti-Racism in Medicine series on the medical education podcast, Clinical Problem Solvers. His leadership in advancing health equity has led him to be named the 2019 National Minority Equity Forum 40 Under 40 Leaders in Minority Health awardee, as well as a 30 Leaders Under 40 Transforming Healthcare by Business Insider earlier this year. It is my distinct honor to welcome him to our grand rounds, and we can't wait to hear what he has to say. Welcome, Dr. Essien.
Thank you so much, Dr. Jobbins, for that introduction. Thank you, Dr. Broder, for being here virtually, and for the chief residents and everyone who made this session possible. Obviously, this is when I was working with Dr. Jobbins to try and secure a date. And Dr. Jobbins, I figured November 4th, I didn't have service. I didn't have any meetings at this hour. And so why not just stick with this date and time? And didn't realize that I'd be giving a talk after 3 to 4 hours of fitful sleep from scrolling through election results. But I suspect that many of you are in a similar boat. And I really am grateful for the time you're taking this morning to share on this really important topic in this talk titled Sustaining an Anti-Racist Academic Medical Center. I have no disclosures to report. So in this talk, I hope to touch on 3 objectives. First, we'll discuss the history of racism in medicine. Second, we'll examine the impact of racism on the tripartite mission of academic medical centers, including clinical care, research, and of course, in honor of this day, medical education. And lastly, we'll identify a few strategies that academic medical centers like ours can take towards becoming and sustaining anti-racism. I plan to address these objectives using the following session outline. First, identifying important definitions, and then again, examining the role of racism on a tripartite mission before, like I mentioned, concluding with our anti-racism strategies. So let's move into our first segment of the talk on definitions. So I like to start with definitions because, as in all areas of medicine, all learners are on different levels. Some of us have deep experience with the topic that we're discussing today. Others are new to it, but I believe it's important for all of us first to understand and appreciate that race is a created social construct and not biological fact. The designations of race have changed significantly over time based on commonly believed inherited physical traits or behavioral differences between individuals and groups. And so, again, important to appreciate that creation over time. Next is the definition of racism, which involves one group having the power to carry out discrimination or judgment or bias over another group, specifically and especially through policies and practices that ultimately shape cultural beliefs that support those same policies and practices. And I highlight those two words here to emphasize that racism is not just the individual interactions, the well-known racist symbols and tropes, but rather it's actual baked into our everyday policies and practices. It's been done so for centuries, including in the practice and study of medicine. I also believe it's important to understand what racism is not. All of the words on the screen here have commonly been used interchangeably with race and racism, but it's important to remember that just as we are specific about the cellular and clinical differences around a squamous cell lung carcinoma versus a small cell while we're teaching on the wards, we also should be direct and specific and precise with language when talking about race and racism. We should try to avoid using words like culture, ethnicity, diversity, or even disparities. All important words, but sometimes are used to potentially explain away the discriminatory practices and policies that we just described on the previous slide. And so with that background and that introduction, let's jump into our second segment of the talk on racism in clinical care. And so in medicine, one of the very first things we learn is the importance of taking a good history. We spend hours before we ever put in our first order developing this skill as medical students and trainees. And I believe that's the same approach that we have to take when it comes to racism in medicine. And so I wanted to share a brief history here, and throughout our talk, I'll be doing the same around how we got to where we are today to be able to understand how we can address racism in medicine, both now and in the future. So while the word race was first used in the English language back in 1508, used at that time to denote family lineage, it actually goes way farther back to how zoologists actually differentiated various animal species. But if we fast forward to the 1700s, to the height of European colonialism, the philosophical leaders of that day landed on two specific theories to explain or try to explain differences by race. The first was the climate theory, which held the belief that extreme heat is what resulted in dark-skinned individuals, and that skin color, and therefore race, would actually change over time with milder climates. Then there, at the same time, was the curse theory, or the belief that darker-skinned Black individuals were naturally inferior because they were cursed due to their descendants from Ham, one of the three sons of the biblical Noah. As we move forward through time into a more, I guess I would quote unquote, scientific origin of race, the leading theories of the day included polygenesis, the suggestion that African people descended from a different ancestor from Europeans, one that was reported to have been closer to primates, and monogenesis, which argued that no, there was only one ancestral lineage, but there's a racial hierarchy with Europeans at the very top and Africans sitting below at the bottom. And so despite leaders like Voltaire and Carl Linnaeus, some folks who may be familiar to us in our undergraduate or graduate studies promoting these theories, They ultimately did fade over time, and the science of race, specifically here in the US, largely focused on Black inferiority, largely focused on legal codifications of race all throughout the late 1800s and into the 1900s. That was until around 1898 when Sir Francis Gallen of England coined the phrase eugenics. Doing so, he promoted the idea of social Darwinism and the extinction of, quote, naturally unselected people, either through reproductive limits or, unfortunately, other more dire measures. Nevertheless, when President Clinton in the summer of 2000 quoted that we are all, regardless of race, genetically 99.9% the same, in response to the completion of the first ever survey of the human genome, you would have thought that the story of race in medicine had finally moved far beyond the pseudoscience of yesteryear and into a new era. However, I would suggest that you pause and hold on that point for a moment, because I would argue that there's actually a risk in downplaying those well-described theories as pseudoscience, as so many leaders in the fields of medicine, public health, and other biological sciences really ascribe to them, many of whom are on your screen right now. From Dr. Benjamin Rush, who believed that, quote, the black color of the Negro is the effect of the disease of the skin, in which he was referring to leprosy, to Dr. Edward Jarvis, whose 1841 publication in the New England Journal of Medicine, which you see on your screen here as well, reported higher rates of insanity in Black individuals who resided in the North versus in Southern states. Data with which he concluded in his discussion that, quote, slavery must have had a wonderful influence upon the development of the intellectual powers of Black people. And so again, I believe the history is so critical because it really does help set the stage for much of the care that we provide today. In a recent publication by Dr. Vias, a resident down in Boston, she described several clinical algorithms which we still use today that have race adjustments baked right into them. From the everyday use estimated glomerular filtration rate, or EGFR, which is really under heavy debate these days, that uses an algorithm to adjust the kidney function of Black patients based on the belief that Black people, for example, like myself, who since the start of the pandemic haven't been to the gym, yet somehow we release more creatinine into our blood because we were reportedly more muscular. Dr. Vias and her colleagues also discussed the pulmonary function tests, or PFTs, a test whose history comes all the way back from Dr. Samuel Cartwright in the late 1700s, the first person to use the spirometer to try and examine racial differences in lung function, and who, through his studies, reported that the lung capacity of Black individuals was 20% that of white individuals. He notably was a slave owner during his day, and he coined two of the most commonly used described mental illnesses of that day: dysesthesia, to describe enslaved Black people who resisted enslavement, and drapetomania, to describe enslaved Black people who had fled from captivity. And so, as a former history major, I could literally spend our entire hour together giving you a history lesson around that history of race in medicine. But I think it's important and so critical to remember that racism's effect happens on clinical care far beyond that history. Racism has been shown to have direct and deleterious effects on our physical health, including resulting in higher stress hormone levels, elevated heart rate, chronic inflammation, and high blood pressure. As Dr. Hicken and her colleagues found in this 2013 study, where they showed that Black individuals, who are represented by the dashed line in this figure, had a higher likelihood of hypertension compared to white individuals, represented by the solid line, the higher their racism-related vigilance score was. This is a score that they created to describe an activated physiologic response by individuals in anticipation of either perceived or actualized racism. And again, the showing of that score and its association with a very specific clinical outcome of hypertension. Racism has severe effects on one's mental health, with prior studies in this area demonstrating higher rates of anxiety, depression, paranoia, and anger in those who experience, again, either actual or perceived racism. These associated clinical symptoms extend far beyond those individual slights or microaggressions that some folks experience on the day-to-day basis, but all the way through to neighborhood, community, and even national episodes of racism, as our current moment belies. Over the last several months, particularly since the now infamous morning of May 25th, when George Floyd was killed, the calls have grown louder than ever by patients, physicians, and researchers alike to treat racism as the public health issue that it is. Those calls, I have to say, were not always so loud. Back when I was sitting in many of you's shoes as a resident in Boston, despite the increasing amount of data that there were to support them. One such analysis was led by Dr. Bohr and other Harvard colleagues, including one of my co-residents, who, studying police killings of unarmed Black men, found that deaths by police not only had immediate consequences on the families involved, but that there was a mental health spillover effect in Black Americans who lived in the same state of that event. They were categorized by nearly 2 additional poor mental health days, or over 55 million additional poor mental health days calculated per year across Black Americans who are exposed to a police killing. Along with racism's direct effect on physical and mental health, racism is also closely tied to the social determinants of health. These social determinants, which we all likely know are the places where an individual lives or works or plays, have all been shown to greatly influence not just health outcomes, but even receipt of health care itself. These factors, such as the ones illustrated on your screen, have all been shown to be strongly associated with racism and discrimination in our country, with minority individuals experiencing higher rates of homelessness, higher rates of incarceration, and unfortunately, higher rates of unemployment, all of which are ultimately tied to poorer health outcomes. So while the world we live in today is in many ways different from the black and white picture on your screen right now, it wasn't too long ago that hospitals themselves were the key drivers of health disparities, specifically through racial segregation. And while, again, this scene may be from over 50 years ago, the repercussions of this legacy continue to play out in our health system today. We know that Black patients, for example, are more likely to receive their care at low quality, high cost hospitals than white patients, as this study from 2011 shows. Dr. Jha and his colleagues demonstrated, there you go. Dr. Jha and his colleagues, sorry, I've got a note on here. I'm just gonna prove that. So Dr. Jha and his colleagues on the slide on your screen demonstrated that as you move from left to right across the x-axis and hospital quality decreases, Black patients were more likely to receive their medical care at lower quality hospitals, which we know has significant implications for the very type of care that they receive. So by the time a patient makes it to us in the healthcare system, racism unfortunately also tends to rear its ugly head, as prior research has shown. In a landmark 1999 study, Dr. Shulman and his colleagues presented cardiologists with the faces that you see here on your screen and asked, with the same clinical story of substernal chest pain, would you recommend this patient for cardiac catheterization? Their findings, again published over 20 years ago now, showed that Black patients, and particularly Black women, were less likely to be referred for this potentially life-saving procedure. Beyond this study, research has shown, including my work in atrial fibrillation, that Black patients are less likely to receive novel cardiac therapies, such as direct-acting oral anticoagulants, novel or traditional cancer care, pain treatment or substance use care, and even less likely to be referred for hospice care at the end of life. All of these data together suggest that racial bias plays a hugely important role, even when individuals are able to engage with the healthcare system. And so I would be remiss if I did not discuss the role of racism in our current global pandemic, which we know, again, has truly laid bare the inequities that have always been present within our health system and our broader society. But when 230,000 unexpected deaths occur over 7 months, those certainly get sharpened into focus. These inequities have resulted in racial and ethnic minorities having poor access to testing for COVID-19, higher rates of infection and hospitalization, and higher rates of death from this novel coronavirus. Nevertheless, these so-called twin pandemics of racism and COVID-19 have really provided us with a unique opportunity to address racism in our clinical care and beyond, including in our research. Which takes us to our next segment of our talk on racism and research. And so here I share with you a brief and by no means comprehensive timeline of the history of racism in medical research, a history that extends upon the commonly discussed U.S. Public Health Service syphilis study at Tuskegee, to include the story of Dr. James Marion Sims, the so-called father of gynecology, who operated on dozens of Black women without consent, often without anesthesia, to develop techniques in gynecological surgery, which not only remain named after him today, but led him to have this statue posted up right across the street from Mount Sinai Hospital in New York City. We think about the late 19th century acquisition of medical school cadavers through the robbing of graves of predominantly Black communities in the late 19th century, to the Holmesburg prison, where I am located in Pennsylvania, where for over 20 years was the site of research studies where predominantly Black inmates were experimented on with radiation. A similar study taking place just a few hours away from where I am in Cincinnati, Ohio. This history is disturbing, it's disappointing, but again, it's also so critical for us to know where we've come from so that we can better determine where we are going as a health system. The role of race and racism in research, again, extends beyond that history into thinking about clinical trial representation, for example. This is an area that has been especially highlighted during the COVID-19 pandemic as we move towards life-saving treatments like remdesivir or the future of vaccination studies. We're seeing a common theme of underrepresentation or hesitancy for trial representation among racial and ethnic minorities. This underrepresentation, though, existed far before the COVID-19 pandemic, as my colleagues and I demonstrate in this figure that's currently under review, where we examined the last decade of atrial fibrillation and anticoagulation studies. And we found huge disparities in representation of racial and ethnic minorities in these trials, including some studies published as recently as last year, the catheter ablation and atrial fibrillation study, or CABANA trial, which recruited as few as 2% of Black participants. And so while that legacy that we reviewed on the previous slide, sure, likely has a lot to do with the mistrust in Black communities across the country, I would argue, like we discussed with some of our colleagues yesterday, that the time is now for us to move beyond trust as a primary issue for why we are not having clear representation of racial minorities in our studies, to truly adapting policies by which we can actually improve equitable representation across these trials. Another key area where race and racism has come up in research is around the use of race as a study variable. In this recent health affairs publication, which I've referenced a number of studies throughout my talk, and I think this is one of the key ones I would suggest everyone takes a chance to read, on the other side of our remarks. Dr. Rhea Boyd and her colleagues called for a new standard of not just publishing on racial health inequities, but for those of us who have the opportunity to review these studies, a new standard for actually critically appraising this work. In their article, they reviewed a number of recent studies that have been published, reporting possible biologic explanations for racial differences, including in the COVID-19 pandemic. And they provide us with a number of recommendations for how we ought to think about race in our clinical trials and study design, a few of which are listed on the screen here. They suggested for researchers to define race early in their design process and specify the reason for using race as a study variable. They suggest avoiding biologic and genetic interpretations of race without providing a social context for that data. They recommend clearly naming racism as a determinant of health disparities. I was recently on a call with a new journal that I'm helping serve on the editorial board and found that over the last decade, despite several racial disparities papers being published, only a handful, 4 or 5, actually named racism as a potential driver of these disparities. And lastly, for those of us, again, who have the opportunity to review studies, they recommend really being critical of work that supports a biologic or genetic difference for racial differences in health. For those of us, again, who have the privilege to lead research, we all know that there's little research done without actual funding. And this is one last area that I'll touch on before moving onto our racism and medical education segment. Late last year, leaders at the NIH published an analysis examining racial differences in funding for independent or R01 grants by that funding agency. The researchers found that across the continuum of the grant process, from submission of applications to discussions of applicants, all the way to the impact score, which ultimately determines whether a grant gets funded or not, that Black applicants performed poorer across the way and were ultimately less likely to be funded than their white counterparts, notably even when studying health disparities topics. As an early career researcher, I can share that there are myriad reasons for these racial differences in funding, but I think what was of critical importance in that study was the finding that the very topics that Black scientists were studying were less likely to be funded. This difference plays out in the underfunding of sickle cell disease research, for example, compared to cystic fibrosis. The scarcity of maternal health disparities research being funded compared to specific Alzheimer's epigenetic studies across the country. And again, I will highlight this as a key reason for why health disparities continue to persist in our nation today. And so how do we get rid of these disparities? How do we start early on to try and address them? I think that does keyly go to thinking about racism and medical education, which does bring us to our next segment of the talk. And so, as you'll likely be used to by now, we'll start off with a brief history about why I think it's so important to realize that racism, discrimination, and segregation in medical education actually didn't exist too long ago from today. The first Black medical school graduate in the United States was in 1847, graduating from Rush Medical School in Chicago, named after Dr. Benjamin Rush, who we discussed earlier. There's the story of Martin Delaney, a Pittsburgh native who was one of the first 3 Black medical students to be accepted into Harvard Medical School. And shortly after arriving on campus was dismissed, along with the other 2 Black medical students, due to petitions from their classmates because they did not want to train with Black students. The first all-Black medical school then was established, Meharry Medical College, in 1876. About 20 years later was the creation of the National Medical Association, created primarily because the American Medical Association barred Black physicians from joining their ranks, a decision that they would not fully revoke until 1968. But one of the more important notes of the history of racism and medical education took place in 1910. That year, a leading educator, Abraham Flexner, penned a seemingly colorblind but landmark report that provided the criteria by which we standardize medical schools up till this day. This new standardization resulted in the closing of dozens of medical schools across the country, which were deemed to be underperforming, including 5 of the 7 Black medical schools that existed at that time. In his report, Dr. Flexner noted that, quote, African Americans should be trained in hygiene rather than in surgery, and, quote, should primarily serve as sanitarians, whose purpose was protecting whites from common diseases like tuberculosis. And so it's with that backdrop that we embark upon the current state of medical education. Despite advances in diversity efforts across the country, there continues to be significant disparities in training of physicians of color, and specifically underrepresented in medicine scholars, or URIM, as defined by the AAMC. Black physicians, for example, continue to make up only about 5% of the US medical workforce. Latinx physicians around 5.5%. And American Indian and Alaskan Natives about 1.3% of the workforce. This publication, when the figure on your screen here, is from the AAMC that suggested that fewer Black men matriculated into medical school in 2014, the year after I graduated, than in 1978, a mere 10 years after the signing of the Civil Rights Act. And so why are there such disappointing numbers? It's recruitment season. Every year, our program directors across the country, chiefs and chairs, are scratching their heads around how to improve the numbers of URIMs in their ranks. Well, sadly, the answer doesn't start with us, right? By the time folks get into medical school and residency, those are the stars across the country. We really have to take a deep look further back and discuss the well-described leaky pipeline of medicine, where students of color move across the process from K through 12 education, which is often based in underfunded, segregated, and under-resourced public schools, through to pre-medical and medical school training with limited role models and mentorship throughout that process, all the way through to faculty, where the numbers of URIM individuals, especially in academic medicine, continue to dwindle. Part of the challenge in seeling this leaky pipeline, again, refers back to the legacy of racism in our country, including specifically in the study of intelligence. So I hope you'll bear with me for a moment. This is Medical Education Day, to take a step back from the physician aspect of education to think more broadly and take y'all back to this around the start of World War I, where psychologist Lewis Terman, who was training back out west in Stanford, trying to perfect this intelligence quotient that he created, or the IQ test. In his analysis over years of data and research, he predicted, along with leading scholars of that time, that my IQ test is going to show, finally, once and for all, that there are significant racial differences in intelligence between Blacks and whites, specifically looking at soldiers who were heading off to fight in World War I. A few years after that study, Dr. Carl C. Brigham, another psychologist, used those results to create, from the government administered IQ test, to then create a racial hierarchy of intelligence, a hierarchical belief that he continued to hold onto as he later developed the first ever standardized admission test, or SAT test, first used to accept students into college at Harvard in 1934. These evaluations of intelligence and knowledge and brilliance somehow seem to have left out the centuries of slavery not too long before these folks were doing their research, where Black Americans not only were not able to even attend school, but weren't allowed to read. They seem to have left out the decades of Jim Crow segregation in the South, again, that kept Black individuals attending under-resourced Black-only schools, not just in primary school and secondary, but all the way through to medical schools, as we've discussed. The topic of examining the role of racism and evaluation on the path towards medicine has also come to the forefront over the last recent years. Last year, the New York Times shared the story of David Velasquez, a third-year medical student who described the often prohibitive hidden costs for low-income URIM students in their medical school journey. From the private test prep courses that many of us have the opportunity to take, tutors for undergraduate training and courses, all the way to the very MCAT exam itself. Not to mention, again, medical school application fees, interview travel, and hotels in a non-pandemic year. In our New England Journal of Medicine article published earlier this year, we applauded the recent pass-fail step 1 grading system decision, arguing that these hidden costs that were described may actually extend beyond the MCAT and a medical school process to result in disadvantages for some medical students of color, and even when they arrive at that USMLE Step 1 board exam, which data suggest that URIM students, unfortunately, are scoring lower than their white classmates. Unfortunately, prior data has also suggested that even a difference as small as 1/10 of a point in a clerkship grade can lead to as many honors grades half as many honors grades for URIM students compared to non-URIM students. And this figure from Dr. Teherani and her colleagues really walks us through the complex process by which all students are evaluated, while also highlighting some specific areas that disproportionately impact students of color, as highlighted in the darker gray. Some of the lighter gray, rather. Some of these areas include differential exposure to microaggressions, either racism on the wards or unconscious bias in our workrooms, especially at an interpersonal level. Within the structure of the learning environment, there's differential patient assessment assignments. I can remember several times during my third year of medical school when my attendings would ask, "Oh, why don't you go see Mr. X? He's another Black man. Perhaps you guys can connect." Which, yes, was often true and was often a real privilege for me, but also was limiting in its very own way. And finally, thinking about the response to allegations of discrimination may also be complicated by trainees who are literally every day being evaluated on the wards when they work with us. It's so important to make sure that the environments by which we provide our students in does offer itself an opportunity for folks to feel comfortable bringing up these negative events, either by members of the team or by patients themselves. I touch on the experience we receive from patients themselves because we know that racism doesn't stop once you exit medical school and throw on your long white coat for the first time. As my good friend, Dr. Uman, shared with us last year in his powerful piece titled "The N-Word," racism can often land its harmful and unexpected blows when we are being asked to do the very job that we trained so hard to do. Sadly, this experience, again, is far too common, as researchers at UCSF discovered in a qualitative analysis of 50 attendings, residents, and students in their institution. Their survey, published in JAMA Internal Medicine, reported significant rates of biased behaviors, ranging from patients refusing care to explicit racist and sexist comments, all the way to even some belittling comments, which may seem benign, but on a day-to-day basis, hearing "you speak English so well" can really start to get to you. Each of these daily threats, unfortunately, contribute to, again, the additional challenges of being a physician of color within our health system. Challenges that do indeed extend beyond undergraduate and graduate medical education into the role of faculty, sometimes in more subtle, but also often in more structural ways as well, including in the persistent othering of faculty members, where patients and family and Sometimes even members of our health teams often refer to me as the transporter staff member, the sitter, the respiratory therapist, really anything else but the physician. We know that the minority tax, as has been described, exists where faculty members of color are regularly asked to support trainees of color or diversity efforts across the institution, work that is often personally valued, but often professionally limited, both in its support and recognition, and ultimately in its leverage towards promotion and tenure. A lack of representation and mentorship of faculty of color at our institutions further burdens the few faculty that do exist, and the confluence of all this often results in lower career satisfaction and higher attrition from academic medicine. And so, what about the actual teaching of our students and trainees? Well, there are certainly important areas and gaps to highlight, as this study from 2016 shows, along with the health affairs paper published by Dr. Rhea Boyd. I think if y'all not had a chance to read this 2016 paper, you should please add that to your reading list this week. In this study, researchers interviewed over 200 white medical students and residents within a large academic medical center in the South. And they found a large percentage of medical students held false beliefs about differences between Black and white patients. This included a fifth of students believing that Black nerve endings were less sensitive than white nerve endings. Nearly 40% of students believing that Black people's blood is thicker than white people's. And over half of the students in this 2016 medical school class, the publication rather, not class, believing that Black skin was thicker than white skin. Again, these findings are not just concerning for educators who are teaching our trainees on a day-to-day basis, but as researchers, they found that the differential in beliefs around between Black versus white patients ultimately did result in differential decision-making related to offering pain treatment to Black patients in that study. There are other important gaps to highlight, as a true rising star medical student, Ms. Nolan, demonstrated in a recent New England Journal of Medicine article titled "Missing the Bullseye." In her study, in her paper rather, she used the example of dermatologic diseases to highlight another key gap in medical education as related to race, noting that, for example, when she was learning about Lyme disease in her first year of medical school in Boston, where obviously that's all we do is learn about Lyme disease, it was solely presented in lighter colored or white skin. One might compare this to when they learned about syphilis in medical school, which has been predominantly presented in darker or Black skin, despite no known or clear biologic association between Black race and the disease. As we've seen on this long journey that we've already been on together, we could easily fill an entire preclinical curriculum with education on racism in medicine. And nonetheless, there's a significant dearth in curricular materials for how to teach about racism in medical school or in residency, with only 17 publications around anti-racism in the past decade. That compared to, on my last check, over 60,000 articles published on COVID-19 since the start of this year. But we know it's going to take, like I mentioned yesterday, a lot more than enthusiastic star medical students or passionate clinical educators, like many of you all on the call today, to help fill these gaps. We're going to need to ensure that there is a competency-based structure at both the undergraduate and the graduate medical education level for anti-racism education, for history of racism in medicine, to really make that work sustainable. And so with that first glance at starting to identify strategies, let's jump into our final segment of our talk on anti-racist strategies. And so before I present my 5 strategies, I'll submit that there have been several of our colleagues over the last few months who have published solution strategies, ideas, and opinions on how academic medical centers, how the health system as a whole can be more anti-racist in their practice. And I would encourage you all, if you haven't had a chance yet, to take a look at some of these references on your screen. But I'll present over the next few slides, and before we hopefully get into some Q&A, what I propose is a 5-step approach, taking some of those lessons learned, taking my clinical and research experience, for how academic medical centers can not just become, but sustain anti-racism over the next decades to come. These steps I've described as the 5 Ds, from desegregating our healthcare system in the US, divesting from racist practice and policy, diversifying our medical workforce. We touched on developing anti-racist medical curricula, and lastly, deepening our investments in the community. And so I'll briefly touch on what I think are critical in these 5 Ds. So first, we have to desegregate healthcare in our country. It's incredible to know that white only or coloreds only waiting room sign that hung back in the late 1960s no longer exists within our health systems. But what does indeed exist is the fact that my clinic panel as a resident looked very different from my clinic panel as an attending. That Black and Latinx, poor and uninsured individuals are more likely to see residents in their clinical practice compared to seeing attendings. And we know how varying resident outcomes can come, for example. We know that across the country, there are still resident-only or Medicaid-only clinics that typically serve our underserved, vulnerable, marginalized communities across the country. And if we don't think about how to, again, put in place policies to address this segregation of care, this second-tier healthcare system, we will sadly continue to see the disparities that we have been describing in decades to come. Next, we must divest from racist practice and policy. I believe that as quickly as hospital presidents and CEOs, chiefs and chairs put out statements supporting the anti-racist cause, that as my colleagues in these publications have suggested in the past, our hospitals need to also quickly move towards being sanctuaries for our communities. Sanctuary spaces for members of the immigrant community whose continued fears around their documentation status has limited their engagement within the healthcare system. To also thinking about, well, who is the first person that a patient walks into in the emergency room or in our urgent care centers? Is it the same armed security guard or police officer that may have triggered their experiences out in the community as well? The creation of safe spaces and sanctuary spaces in our hospitals to protect our communities and protect ourselves as providers is one that I do believe that we can achieve by divesting from certain policies and practices that are in place. I've touched on this a bit around how to and why and the importance of diversifying the medical workforce, but it's really interesting to see time and time again studies coming out suggesting the racial concordance between a provider and a patient truly resulting in improved health outcomes. Many of you may recall the Oakland barbershop study in 2018 that got a lot of press on National Public Radio and one of their podcasts, Hidden Brain, that talked about how having a Black physician made a Black patient more likely to accept the flu vaccine or accept screening for colonoscopies. And in the 2020 paper published in the Journal of General Internal Medicine earlier this year, a similar finding took place where patients were actually given the faces of the doctors on your screen and asked, would you go for a CABG? Would you consider receiving a second opinion if someone told you to go for a CABG? And again, noted a pretty clear and distinct racial concordance between accepting procedures and having a physician of color if you are a patient of color. These studies, again, especially within the current global pandemic, highlight the need to push our numbers of underrepresented in medicine physicians from far beyond the numbers we're seeing today. I spent a lot of time talking about our medical education space and the importance of developing anti-racist curricula. Amazing to have talks like what we are having today as a big part of our medical education training. I wanted to quickly highlight the Clinical Problem Solvers Anti-Racism in Medicine podcast that Dr. Jobbins mentioned earlier. Another platform that we're using to try and keep this message, not just within our textbooks and our residencies, but also thinking about how we can reach audiences that aren't typically reached through settings like this. And lastly, but certainly not least, we must deepen our investments in the community. I mentioned earlier that today's talk was going to largely focus on the tripartite mission of clinical care, research, and medical education. However, we know that several academic medical centers are moving towards a quadruple mission, the fourth leg of which involves engaging within the community. And I was able to quickly pull out the Bay State Medical Center's strategic plan at the start of this year, published out in January, which showed a number of potential drivers of health and health outcomes within the Springfield community, and places where, the medical center may not have direct impact, but certainly can have indirect influences, whether it's on housing needs, on food insecurity, on the very social environment itself. And I think this is such a critical area that if we do continue to, not just financially, but through man and woman power, put in efforts into this work, we can really start to see a change in the disparities that we're seeing across the country. And so in this talk, I hope we were able to address the following objectives: discussing the history of racism in medicine, examining the impact of racism on that tripartite mission, and lastly, identifying strategies, the 5 Ds, for how we can make our medical centers and sustain anti-racism within them. I've literally ended every talk that I've had the opportunity to give this year with a vote of hope, with a quote that inspires, a quote that says, the pandemic has shown us that things are hard, but things are going to be okay. But as I mentioned at the start of the call, I spent a lot of last night wondering if that was actually going to be the case. And so my dad's a pastor, and a lot of our childhood growing up, he would force us in some ways to memorize verses. And this is one that particularly he highlighted for us as kids. Now, faith is being sure of what we hope for and certain of what we do not see. And on a day like today, I have to remember that there were folks who came before us who saw the world very differently than what we see it today, who never believed a lot of the conversations that we're having today would happen. I'm hopeful that seeing some of this history over the last 50 minutes or so inspires us to remember that we have a long way to go. But I also hope, and I do hope that one day, in 5 years, 10 years, 20 years from now, we'll be able to finally see some of the changes that we hope to see. And so thank you so much again for the opportunity to share with you all today. And I really appreciate your time. Thanks.
Dr. Essien, thank you so much for that amazing talk and opening our eyes to so many different ways that we can be anti-racist within our academic medical center. There's a couple questions that came through on the chat. If that's okay, if you have some time, I'd like to ask you if that's okay.
Of course.
So one was, if you could speak to the effects of socioeconomic status on those issues and whether they need to be differentiated from racial issues, or is the solution to address both?
Yeah, really important question. Thanks so much. I think the socioeconomic issues are real. I live in Pittsburgh, in a city that straddles a number of lower income communities, a city that straddles a number of segregated racially communities. And I think this issue of socioeconomic status continues to arise. I'm privileged that I got to title this talk Sustaining Anti-Racism, and it wasn't a broad health equity talk where folks can say, well, what about these groups? So I do want to focus my remarks on racial and ethnic minorities and the health of those communities. If we look at college-educated Black women, for example, we see that they are 6 times more likely to die during childbirth than college educated white women. These racial disparities cut across socioeconomic status. They are why I went into this work, seeing a 2016 study that showed that regardless of your income, as income rose, Black men were more likely to die from cardiovascular disease than white men. I think the focus on socioeconomic status for so many of us is in a way has limited the work that we've been able to do. And so driving this conversation towards a focus on racism is really important for this moment.
Thank you so much for the answer. Next question is, through the lens of the current pandemic, could you please speak about the specific impact of striking lack of URMs in the hospital leaderships, C-suites, and management on patient outcomes and patient satisfaction?
Such an amazing and important question. Again, one of my last slides was showing that Journal of General Internal Medicine study talking about racial concordance of providers. And I think it does go back to higher level rather, to thinking about the diversity of our hospital leadership. It was really interesting after May 25th, like I mentioned, to see how apt certain hospitals were into, again, statements which for now may not have been as powerful as we had hoped, but we're able to make quick statements around the death of George Floyd, around how we need to move our health systems towards anti-racism. Those often came from leadership that was more diverse, whether it's by gender or by race or ethnicity. And I think that means something. I think if our leadership is diverse, our trainees will be diverse, our patients will receive that they are being welcomed within our health systems, and for sure will improve our satisfaction outcomes. And so I think that's a critical step. We have a long way to go. If 5% of physicians in the country right now are African American, how are we going to distribute that across the leadership of our hospitals across the country, right? So lots of room to improve there.
And lastly is, how do you think we can increase the number of Black physicians, which is very telling with the point that you just made? And do we use our political capital in advocating for a more equitable and elementary education?
I'll just say yes. I think that one of the comments I made to our trainees and folks on the call yesterday was using our voice. I think trainees have an incredibly loud voice. Physicians have an incredibly loud voice. I gave a talk for the American College of Physicians this past weekend, which has a huge advocacy arm. I'm sure many of the societies that folks on this call are on, either subspecialty societies or general internal medicine societies, also have advocacy arms. We can start fighting for K through 12 education to be better funded, for taxes to not be the main source of public school education funding, when we know that there's segregation in housing and income and unemployment, which results in that poor underfunding of our schools. And so, yes, please use your voices in any way that you can to help make a difference across that pipeline.
And I just wanted you to know there's many notes of gratitude and thanks to you in the chat. So please take a look at this. Dr. Broder's children are actually listening from the Bronx and from the ER. So when you get a chance, go ahead and read through those. Does anyone else have any more questions? I've given you a chance to unmute if anyone would like to ask a question specifically.
Hi, thank you so much for your presentation today. Not so much a question, but more a comment, I think, for our white colleagues who are very invested in this work, creating space for people of color and underrepresented groups to have a voice is going to sometimes involve stepping back a little bit in order to amplify those voices. So, seats on committees and things like that sometimes diversifying those spaces may involve people taking a step back. And that's a difficult step for a lot of people.
Yes, no, I think these are conversations that are happening across the country. I shared again with with the folks who joined me yesterday, my 3 tips for listen, learn, and lead for how we get through this moment. And I think that last L of lead comes from sponsorship. Dr. Jobbins and Dr. Shaban, I believe, were incredible sponsors in seeing this talk as something that should not just be coming in on a diversity day or just a talk for the residents or just a part of a diversity curriculum, but to go forward to the whole entire department. And I think that sponsorship needs to continue to happen across the country. I'm sure that there are amazing, incredible trainees, faculty members at Bay State, at UMass Med, across the spectrum that could be giving a similar talk, whose lived experiences, clinical research experience are quite similar to mine. And I don't yet know them, but I'll be sure to do my part to help sponsor and advocate for them as well.
Thank you so much. Oh, go ahead, whoever just unmuted.
Can I make a comment, please?
Of course, Dr. Broder, go for it.
I am just overwhelmed with appreciation for having this subject discussed by such a knowledgeable person. I wanted to express my appreciation to the leadership of the residency program for picking the subject and finding such an enlightening speaker. I had an opportunity to talk to him yesterday, and I'm sorry that he couldn't be here physically, but this has been an extraordinarily interesting Grand Rounds, and I'm just honored and grateful to have had some sort of a part in it. Thank you very much.
Thank you so much. Honors was definitely mine, and so wonderful to meet you, virtually at least. And you're really incredibly honored that your children are on the call. Some positive ways to start my morning.
All right, well, that will be the conclusion of our Grand Rounds. And thank you so much again, Dr. Essien and Dr. Broder. I hope everyone has a lovely day and tries to find some hope in it as well.